Morning and welcome to the Davies Use Case webinar being presented by Advocate Health on using health information technology to drive more appropriate test ordering. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Course promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It is my pleasure to welcome our speaker for today's webinar, Anupam Goel, who's the VP of Clinical Information at Advocate Healthcare and also the Inpatient Chief Medical Information Officer. So, Goel, I am going to turn this over to you. As I make you the presenter here. And start when you feel when you're ready.
Okay. Arnold, thanks so much. It's my pleasure to talk a little bit about Advocate's experience using health information technology to improve more appropriate test ordering. So, we've got several hospitals with lots and lots of inpatient beds. We also have hundreds of sites of care in the outpatient setting. We've got 6,000 docs who are either employed by us or affiliated with us, so 6,000 physicians on staff, and we have over 10,000 employed nurses, advanced practice clinicians. So we're spread over much of Chicagoland, and we have some locations in central Illinois. Today is repeat testing, and so we felt that this was a real challenge for us and other members of the healthcare field. Many people order tests in the inpatient setting out of habit, and so day after day, the same test may be ordered over and over again, even if test results are normal or if the patient's clinical condition had not changed. When we did some more investigation into the why this repeat ordering was occurring, we could really divide the universe into three spaces. One is the daily labs. You order the tests every day as a reflex, so that's what your specialty does. Another one was once a stay, where we would have multiple tests of the same type that shouldn't change in the course of a routine hospital stay, like an A1C or a lipase, but would be ordered over and over again. And then finally, a test that should be ordered only once in your lifetime, and that one is really genetic testing, where the test results should never change. It's more a question of, can we get that information to the ordering user before they place a repeat order for a test that doesn't need to be done again. So when we think about these three domains a little in more detail, we can think about, I'm going to flip the order here. Once in a lifetime, really, when we talked to the users and did some analysis, what we found was the challenge that the user was facing was, is it more work to try to find that test result in the ocean of information about this patient, or can I just order the test and get the result back to move forward with our diagnostic or treatment plan? For once a stay, it was really important to say, can we get adoption around new ways of thinking about diagnosing or treating disease? We mentioned lipase for pancreatitis, and it's pretty clear from the evidence that lipase should be ordered once and not repeatedly for the diagnosis of pancreatitis. There may be some people who feel differently, but in general, most gastroenterologists and general hospitalists feel that a single lipase is sufficient. This probably has a considerable opportunity for improvement at Advocate, and we suspect other healthcare systems, and we wanted that to be one of the foci of our quality improvement initiative. A frequent, but maybe not as clinically glaring problem is the once-a-day testing, and this is the idea that I'm going to order tests every day because someone is going to ask me about the patient's improvement, and perhaps I can detect things that I would not detect by a clinical evaluation using laboratory test results. It's an interesting challenge. It's probably an avenue of extreme waste, in the sense that people have noticed that you could reduce testing by 60 to 70% in this domain and see no change in clinical outcomes. But there's no clear clinical champion who says this is the right thing to do. We actually did some work on our side to think about feedback reports and alerts and utilization patterns, and historically at Advocate, those pilot attempts had not done very well. So here's some baseline data. I'm going to focus really on once a stay because I think that's the story we want to share with all of you. Here's some tests that we think are reasonable to think about doing it once during hospitalization. We don't expect them to change very much over the course of a 4 to 7 day hospitalization. And the fact that these tests are being ordered more than once during the stay represents a quality flag or a missed opportunity. And so you'll see the volumes here and the number of tests that are ordered. It turns out there is no correlation between the number of tests that are ordered and the cost to the healthcare organization. So we were not able to tie them financially with the behavior pattern as well as we'd like to have. But the idea is that some tests are ordered more frequently during a stay than we think is correct. So what do? We thought about how we might design this process. The way we wanted it for once in a lifetime is to really clamp down on genetic test ordering and say, you know what, we need special permission and validation that another test is not required for this patient who's had a genetic test result in the past. For once a stay, we spent a lot of time trying to generate clinical consensus, and then once we had consensus, we used the EMR to help enforce that evidence-based consensus approach. If we were unable to reach consensus, we didn't go after those tests. So the two that we thought were interesting, as I mentioned earlier, were lipase and BNP. And so even if I can speak about the evidence, it wasn't strong enough to convince some of our clinicians, and so we didn't go after those. We focused really on the ones where we had high evidence and high consensus. And then for us, we were really also looking for ways to focus on once-a-day testing and trying to suggest to the user, hey, this patient's last 2 blood tests were normal. Do you really want another one? When we did this alert trial, we found that the alert was overridden 95% of the time, which is really challenging. And so the lab utilization committee at Advocate made a decision to say, what we can do, if we can't stop the ordering in real time, what we can stop is future ordering. And so we'll stop people from ordering 48 hours in the future, assuming that the test results aren't negative. And the paradigm here was that you should evaluate the patient before ordering the next set of tests. So here's that same list again of tests that are once a day, and we talked about the 4 tests that we wanted to focus on. Lipid panel really shouldn't change over the course of a week. C-reactive protein, A1C, a test for glycemic control, and then thyroid function. So part of the clinical work was really getting endorsement, and this short write-up talks about a communication we had to our physician leadership and other ordering providers about how we might reduce the excessive ordering. So it talks a little bit about the why, it talks about the how. At the very end it says, when's the go-live date from an EMR perspective. So for this conversation, we really wanted to focus on those 4 tests that are once a stay. And if the user placed an order and the test was already in the system, we'd have an alert that shows up on the right. That test looks like this, and the text may be a little hard to read. I'll read it out loud. The patient already has an A1C glycohemoglobin test within the last 56 days. Consistent with the Lab Utilization Committee's recommendations, this order will be canceled, and so we gave the user no choice except to say the order was canceled. There also is the result from the prior test with a date and time. If for those clinical scenarios where someone felt that the lab was erroneous or there was some overriding indication to repeat the test, the user had the opportunity to call the lab and have those team members override the test request. So clinical consensus, validating the technology, and then communicating that change over some details about how we can empower the user in real time to decide what to do next that was appropriate for the patient and the clinical scenario. Okay, so what do we find? Did a quick look at test ordering per 1,000 patient days, and we just did a rolling 6-month average, and so you can see our work over the course of 2 years, and you can see this time period before June of 2016 where we had some behavior, and we monitored behavior afterwards. So that announcement that I showed a screenshot of was deployed in the early summer of 2016, and that arrow represents the change point. For once a lifetime, really not a whole lot. Really, it's up, it's down. The work seems to have occurred right with the change date, and then once it happened, we kind of stayed where we were. So that once a lifetime genetic testing seemed to do really well, and that was really the hard push to say you don't get to order it again. The once a stay, you also see a decline from 51.6 per 1,000 patient days down to 46.5, and that effect seems to persist, which is very exciting to see, that we weren't seeing an increase in the once a stay testing like the A1C and the TSH. And then the once a day, the CBCs and the Chem7s, we really didn't see any difference at all. It really didn't seem to make any difference how we sliced that out. We actually compared the pre and post using a two-sample unequal t-test with a two-tail distribution, and the once in a lifetime, really that shift to say you cannot order genetic testing without prioritization made a huge difference. The once a stay, also a smaller effect clinically, but it is statistically probably real. The small difference is probably real. And then the once a day, we were unfortunately dismayed to say that the intervention that we had about stopping future testing in 48 hours did not make a long-lasting change. Another way to interpret this is looking at dollars spent per 1,000 patient days. The once a lifetime, although very effective statistically, in the recent number of tests, you don't see a big change in dollars spent, and I referred to this earlier. The once a stay, it looks like we saw a small but real decrease. We saw higher spending before, and then that number dropped down. And then once a day, if you think about it from a financial perspective, really that's where the opportunity lies in reducing expenses to the healthcare system, and we were not able to make that change as successful. I will say that several articles have come out year after year around choosing wisely and looking for ways to provide audit and feedback. At Advocate, at least, we've had trouble getting people to think about once-a-day testing differently than what they've been taught in training or earlier in their career. We need to do a better job understanding the audience's receptivity to change and recognize what limitations the technology might have and how it might be accepted in different circumstances. When possible, use national initiatives and system committees to help gain the necessary political support to make a change that's this large. And we found that that was much stronger for the once-a-day testing with clinical evidence than we did for once-a-stay or even the lifetime stuff. It's important when you think about these types of initiatives, if you're going to spend the energy to make these things occur, to find those big-ticket items to make significant contributions that you can then use to push back when there's resistance internally. We did not do that, and if we had to do this all over again, I think we would focus on high-revenue items to help make the case that we're doing other things for the healthcare system to add value. And then finally, following utilization reports to keep track of when we are doing work that is sustained versus that's only going to fall back to the mean. And I think that last slide talks a little bit about ordering behaviors well after the intervention to make sure that the effect that you wanted is sustained long term. To you.
Okay, that was good and quick and to the point. Again, thank you for another great presentation. So let folks know where to go find this recording and other Davies use case webinar recordings, as well as how to apply for Davies Award, and that can be found posted at the HIMSS website, the HIMSS Davies Award website at hims.org/Davies. Again, that's hims.org/Davies. And thank you so much.